I thank the panel for being here. And Dr. Harris, I think that with the shortness of time, I think you've identified the problem is the lack of primary care. I believe that we recognize that 2% of our classes are going into primary care, and our primary care providers are aging and moving off the stage, so to speak. The obvious to me is that why aren't we using our nurse practitioners, our PAs, more aggressively, and why aren't we empowering them in each state to be our primary care providers? Because if we started today, it would be a decade or maybe more, even if we could incentivize the primary care provider to go into primary care, so to speak, and if we could incentivize them to be distributed properly, it would be a long time coming. And I believe that the American College and the AMA and the American College of Surgeons could go a long way as far as our healthcare problem is concerned if we could identify the restrictions that are centuries old on what someone can do for a patient, whether it be order a mammogram or an x-ray or work up that patient. And the other thing that we're not saying is that physicians are trained with an emergency room mentality. And we know that half of all of our deaths for the next century are going to be lifestyle-related deaths, and trained physicians are very poorly trained to take care of the young family, advise the mother on nutrition, walk them through a holistic type approach. And I believe that that's where we're gonna fall down as far as our obesity, diabetes, hypertension, neonatal care, and many of us from rural areas have seen this over and over and over again. And it appears that we're training these well-trained PAs. They're taking care of our men and women in Iraq right now. They're in every U.S. embassy, but yet we don't allow them to practice in the United States.
Mr. Griffith, the American College of Physicians, I think, couldn't agree with you more that we need a team-based approach to health care, and modeled again on an expansion of primary care with offices with a team of people, including nurse practitioners and PAs. We met with many of the leaders of the nurse practitioner organizations just last July to talk about how we could work collaboratively to try and improve the quality of health care. We just published a paper that said that we believe in the CMS demonstration projects, that they should also consider looking at nurse practitioner-led medical homes. Now, as you know, that's controversial, but the reason we did that is we're being utterly pragmatic. I think I'm right about this. 28, if I have the number right, of the states plus the District of Columbia allow nurse practitioners to practice without physician supervision. And of the remainder that require physician supervision, only one requires that the physician be on the premises. Thus, it makes sense to look at that model. Now, the second part of your question about essentially scope of practice, that is defined by each state, and it differs from state to state. We applaud the notion of people practicing within their scope of practice, but not exceeding it. We still believe that the best medical home is one headed by a physician, and particularly with the chronically ill patients in this country. 23% of everyone on Medicare has 5 or more chronic illnesses. We believe they certainly fit into the scope of practice of a well-trained physician, primary care physician.
Well, I appreciate that, and I would say to Dr. Moffitt that in every physician's exam room is a plaintiff's attorney. So if you're wondering why those patients are readmitted from a nursing home or an intermediate care facility, it's because the family is there and the physician is there, and he is basically saying to himself, I really don't have a choice. I know I shouldn't readmit the patient's terminal, but there's a plaintiff's attorney lurking there somewhere. And I think that is an issue that we haven't discussed but has to be addressed.
That's a good case for medical malpractice reform.